This is a short presentation on spinal tumors. When we talk about spinal tumors, we mean both tumors affecting the spinal cord and tumors affecting the spinal column. Spine tumors can be grouped into intramedullary tumors, intradural extramedullary tumors, and extradural tumors. The clinical profile of these tumors can be as neurological syndrome or as skeletal syndromes. Spinal tumors can be intramedullary. Intramedullary spinal cord tumors include astrocytomas, which are more common in the pediatric age group. They are more common with neurofibromatosis type 1. Grade 1 and grade 2 tumors constitute 90%, and grade 3 and grade 4 tumors can also be present. Spinal astrocytomas do not offer a clear demarcation plane between tumor and cord, so total resection may be difficult. Many of these tumors, especially the more malignant ones, may require post-operative radiotherapy. Ependymomas constitute 70% of spinal cord tumors in adults. These are more common with neurofibromatosis type 2. Ependymomas are surgical tumors. They offer a clear demarcation between tumor and cord. Other intramedullary tumors include hemangioblastomas, brilliantly enhancing multiple tumors often as part of the von Hippel-Lindau syndrome. Intramedullary metastasis may also be present. Intradural extramedullary tumors include peripheral nerve sheath tumors like schwannomas and neurofibromas. Meningiomas are also intradural and extramedullary. Phylum terminale ependymomas are also intradural extramedullary. Extradural tumors may be metastasis, commonly from breast, prostate, or lung. They can also be from the renal cell malignancies, myelomas, and lymphomas. There are certain clinical syndromes associated with spinal tumors. These clinical syndromes can include pain syndromes. The pain may be radical along a nerve root, or it may be funicular, where there is a diffuse pain. Skeletal pain may occur when there is bone involvement. Usually it indicates pathological fractures. Neurological syndromes may vary from paralysis to plegia, and depending upon the location of tumor, the patient might develop quadriparalysis or paraparalysis. Brown-Sequard syndrome may be found in laterally located tumors. Here, there is loss of ipsilateral motor and spinothalamic sensation and contralateral posterior column sensation. Anterior cord syndromes are usually more of motor involvement because of corticospinal involvement. Posterior cord syndromes, you have early loss of posterior column sensations. Intramedullary spinal tumors and the syringes which are associated with them may produce a central cord syndrome. The upper limb may be affected more than the lower limb, and bladder and bowel involvement may be early. Spinal tumors may be associated with skeletal deformity. Kyphosis is more common when there is an anterior column collapse. Scoliosis is more common when the paraspinal muscles are paralyzed. This often occurs in intramedullary tumors. Imaging modality of choice is an MRI. MRI spine will show us bone involvement, including collapses, bone expansion, and also bone marrow changes. If the spinal cord is expanded, an intramedullary tumor needs to be suspected. We need to give contrast to delineate the tumor. Cord displacement to either side or even anterior-posterior is a manifestation of intradural extramedullary tumors. If the tumor is dural placed, it's a meningioma, and if it is extending to the foramen and may be dumbbell-shaped in a neurofibroma. Extradural tumors may be associated with bony expansion or destruction. If there is a doubt of metastasis, a search for primary is warranted. Contrast administration helps to diagnose, delineate a tumor, and also gives information regarding its vascularity. A craniospinal survey may be indicated if there is CSF dissemination, as in an ependymoma, or even if there are multiple tumors, as in von Hippel-Lindau. Spinal tumors are predominantly managed by surgery. Pre-operative localization is done for incision planning. This might involve pre-operative placement of a marker or may just require a C-arm. A laminectomy is usually done considering the craniocaudal extent of a tube. Laminotomy and laminoplasty are options where the posterior elements are preserved. A hemilaminectomy can sometimes be done, preserving the tension band. Dural opening is done to give access to the cranial and the caudal ends of the tumor. Retraction sutures placed in the dura decrease the epidural bleeding and also provide access. A T-cut may be required for more ventral access. A duroplasty may be done for canal expansion in case there is a likelihood of further cord expansion, as in an incomplete removal of the tube. Dural closure is usually by continuous sutures using 5-proline, and a round body needle is preferred so that CSF leak chances are less. A myelotomy may be required for intramedullary tumors. This might be a midline myelotomy or a dress zone myelotomy. Pile retraction sutures are used by many surgeons to keep the myelotomy open. Intraoperative monitoring may be used when available, especially for intramedullary tumors. SSAT will give us an indication of cord damage and helps us to tailor a resection. Intraoperative steroids are often used, and methylprednisolone may be given preoperatively, or even dexamethasone is usually used. There may be a requirement for stabilization in case there is bony involvement. Post-operative management, mobilization protocols. Mobilization is started early if there is no neurological deficit. CSF leak prevention is achieved by meticulous closure, by usage of fibrin glue, and by keeping the patient in a prone position if a CSF leak is suspected. Radiotherapy may be indicated. Craniospinal RT may be given where there is CSF seeding. Radiotherapy is also indicated if there are metastases and for higher grade intramedullary tumors.